Hello and welcome to Deep Dive with KPMG East Africa, where we bring you insights, analysis, and expert opinions on key issues shaping the industry and economies today.
Hello and welcome to Deep Dive with KPMG East Africa. My name is Victor Omurunga, an Associate Director in Advisory. In today's episode, we shall be discussing healthcare financing, the developments that are happening in this space, from health bonds, social bonds, green bonds, PPPs, and results for payment. And to help us discuss this important topic, we are happy to be joined by Dr. Matiko, a health financing expert. Karibu Daktari.
Thank you, Victor.
So, Dr. Matiko, I know you're a very busy person and it's been very difficult to get hold of you. So we are very pleased to have you on the show today. So before we start into the serious business about health financing, could you please tell us one more thing that we should know about you beyond you being a doctor?
Yeah, so I think one of the things that my friends know quite clearly is I'm a reggae fan.
Okay, interesting.
So interestingly, because a lot of people are like, oh yeah, but you don't look like a reggae guy. But looking at, of course, it's expected to have dreads, but, the happy dreads.
Okay, that's a very interesting discovery, mostly for a doctor. Most of us have assumptions that doctors wouldn't listen to reggae, but so it's good to know.
Yeah. Thank you.
Thank you.
Yeah.
So, Dr. Matiko, as we start discussing this topic, could you briefly talk to us about your role as a health financing expert? What do you do on a day-to-day basis?
Good. Yeah. So, I'm a health financing expert. I've been doing this for the last 10 years. Currently working with the Clinton Health Access Initiative, where I lead our technical support with technical support for governments across the continent in shaping the health financing ecosystem. Different countries have different questions they're asking, and I think my role is then, one, help them figure out how this happens, but secondly, enable regional exchange in terms of how countries learn from each other in approaches to use.
Okay. Fair enough. And just building onto that question, why did Chai decide to venture into sustainable health financing?
Yeah, so interestingly, if you look at the health systems across the globe, there are a couple of things that are happening. One is countries are growing economically. When countries are growing economically, a couple of things tend to happen. The first thing that has happened is, especially in low middle income countries, specifically Africa, is donors are transitioning out. So there's less resources available from donors to the African continent. And so there's a drive to improve resources, especially domestic resources, to respond to this sort of donor transition. Secondly, traditionally Africa was always a place which was sort of considered a home for communicable diseases or infectious diseases. But that is again changing. We're having a rise in terms of non-communicable diseases that growing need and to shape health systems differently. But finally, there's a political push to achieve universal health coverage. To achieve that, then it's becoming imperative that governments drive domestic resources over and beyond what has traditionally been dependent on donor funding.
Fair enough. And just to quote a few statistics from what I've seen, what governments are doing across Africa in terms of healthcare financing. For example, I've seen governments setting aside 5 to 10% of their budgets, which is way below their Abuja declaration. For example, if you look at the average per capita spending for government, again, is below the recommended international health organizations set standards. So what can governments do to ensure that they kind of meet these targets in terms of financing?
Good. So, there's a whole discussion around, especially that takes two perspectives, that we need more resources to health, yes, but even within those resources that we do have, we need to utilize them more. And so there's a drive that now has become known to be like, it's either as we look for money for health, there's also need to get more health from the money that we are investing in. And so more as governments try to look, and I think we'll explore that probably in terms of what are they doing to get more money, but also in equal measure to see how then do we use the money that we have more efficiently. But if you're looking for more money, of course, traditionally we've been dependent. Largely, especially when you're talking about low-income countries, more so in Africa, development assistance for health has played quite a significant role. And we're getting into donor fatigue. I think a number of people have called it donor fatigue. But interestingly, other people can look at it as most of the countries that have traditionally been funding our health system are looking more domestically within their countries. And so there's less focus around the continent of Africa. And so to raise domestic resources for the continent, then a number of countries are coming up with a couple of other approaches. So do we opt to raise budgets for health? If there's room for that, well and good. But again, healthcare needs are quite extensive, and sometimes it's hard to fulfill all the needs that the population has. And so what more do we do? Most of them are moving to more non-traditional ways of raising that fund. So if we look at maybe countries like Gabon that have been doing, getting part of the airtime, expense on calling rates to fund health, a proportion of that, I think that has played a significant role in terms of mobilizing resources for them. Look at countries like Ghana taking a proportion of their VAT and earmarking it for health. That has played a significant role. And our neighboring country, Rwanda, has chosen a number of other options, including traffic fines, a proportion of that going to health. So there are a couple of them that are coming up with more interesting ways to get into that. And of course, not forgetting approaches that other countries have used in terms of private-public partnerships. But how do we harness some of the private money into the health sector to enable availability of those resources to drive that? And so that's on mobilizing resources. And when you're talking about enhancing efficiencies, traditionally we've always had, let's push money, let's buy commodities, let's get health workers, let's build infrastructure to deliver health. But that is slowly changing, whereby let's invest more on the outputs. So all of us are going back to say, yes, we're putting in money, what's the quality of service that we get, a number of lives that we save, or even how it's the client satisfaction or the patient satisfaction in terms of what you're getting out of that, so that we're linking the money you're putting in, but also being quite clear that we're getting what we're supposed to get.
Understood. And just to build on that topic, I know you've mentioned about traditional financing, and really the landscape of financing is changing across the globe, and Africa has lagged behind in this space. Would you just briefly talk to us about the evolution of the health financing, and then just talk to us about what are the new things that you're seeing? For example, I've heard people talk about health bonds. I've heard people talk about social bonds. I know you've mentioned about payment for results. Those are some of the new things I've heard coming up. Are those things feasible in Africa? Can we actually achieve that?
Yeah, so absolutely. I think I'll probably build on from the element you talked about, especially looking at the traditional ways where governments are coming from. So different countries, of course, have a different history in terms of how they've evolved in their health systems, largely dependent on their colonial legacy. So, for example, most of the countries that are leaning on were colonized by the Brits will sort of more have evolved from a more tax funded, because historically, I think the Brits have moved more from more tax funded, and others have embraced social health insurance traditionally. But if you look across all of them, it was largely centered around government ability to provide these services. So either through free care programs or through some kind of input financing. So traditionally that has been the case. But how has that evolved, and what has informed the evolution? You see slowly, more investments in the health sector, driven by the advocacy that has come from the populations. But the other bit that has played a role is the global push. Either if you're looking at some of the disease programs, be it HIV, TB, so a lot of donor money coming in to influence certain approaches that governments are pushing, but also the technical support that have been offered in the long term. So if you're looking at that kind of evolution, then we're moving to a point, and I earlier mentioned that as we move, due to certain realities, that donor funding is going down, and the other realities that we do have, especially around disease epidemiology, then there is need to drive domestic resources.
Yeah.
So for us to drive domestic resources, there are other approaches, and I think you mentioned a couple of them, but happy to delve into it. So PPPs, I think highlighted, that's private-public partnerships. It's largely around how do we harness private capital to advance access to such an important health service, social service such as health. Yeah. But the other bit that becomes interesting is issues around, let's say, social bonds or impact bonds. Yeah. One is acknowledging, it brings on board private capital, but with an aim of buying certain impact. Yeah. That, for example, one of the elements that we, has just been, it's being tried in Kenya is how do we improve access to family planning for adolescents, but also have private investments or an impact investor that is looking to sort of create an impact in such an area. Yeah. But I think the bigger challenge comes around how do we harness these private investments or impact investments, and what sort of incentives do we have as a government or in the health sector to do the same? Because it's easier to do that when you're talking about bonds for infrastructural bonds, but impact then has other incentives in terms of how we can drive that. But it becomes an interesting way in which you can, different governments are trying to explore how to do specifically for certain outcomes.
Sure.
Yeah.
Sure. And actually moving closer home, I know the government has been pushing for reforms in the health sector, just to ensure that we achieve the universal healthcare sooner. And I think there have been a number of acts that have come up, right from the Facility Improvement Fund, the Social Health Insurance Act. So as the government tries to achieve these reforms, what would you tell them to explore? What should they do to explore to ensure that they get this sustainably?
Good. So I think if you look at the many different acts, which I think currently, as you've listed, we have the Social Insurance Act, the PHC, that's Primary Healthcare Act, Digital Act, and the Facility Improvement Act. So the overarching aim is not only mobilize more resources, but let's ensure that the resources we're mobilizing actually translate to service delivery. So the Social Health Insurance Act then aims to say these are given mechanism that will raise its resources either through direct payroll deductions, especially, I think it's prescribed to be about 2.75 for the formally employed, but also with a plan around how do we get some of these resources from the informal sector, which you'll argue it's a challenge, but I think they're trying to figure that out, especially around how do we do means testing to target clearly around how we, have differential premiums for the different levels in terms of income levels. So which becomes an interesting piece. And so that one of the biggest challenges, if you look at, for example, the FIF or the Facility Improvement Funding, what has been is, yes, you can raise money, but that means nothing if it does not translate to the service being delivered. And so one of the key bottlenecks have always been, yes, money goes down to the facilities, but then it goes back to the county revenue fund. So what becomes important is let's have facilities have autonomy to plan and budget for the resources and actually enable the service to be delivered at that stage. And so that has largely been the case. But I think to your question around what more can the government do is, yes, we have a plan for the formally employed. I think there is still a lot to do in terms of how do we harness the informal sector for us to get all the resources that we do need. Secondly, yes, it's not enough to get the money there. How do we adjudicate quality of service? But most importantly, how do we keep both at the health provider level accountable for the health outcomes? So that sort of things, and I think there's been efforts around pushing through a law around quality of care law, which I think plays quite a significant role. And again, also looking back to, two items that continuously bring a challenge. Commodities, we have to ensure that commodities at the facilities, because that has been a challenge, and the human resource for health. So frequent strikes by health workers, of course, remains a significant challenge that we're having to deal with, but it will be important for us to figure out, with all these laws, how do we then provide solutions to some of these areas.
Fair enough. And I think you bring up a very important point, right from the different building blocks that support a strong health system. Yeah. So when you think about, say, the human resources, right, from the policies that we have in place, the infrastructure that we have at the facilities, for someone who is not an expert, or for a common person who doesn't understand health financing, what would you tell them what would you tell them as to why health financing is an important building block in this space?
Good. So yeah, and I think it's important you brought up the whole element around the health system.
Yeah.
And I think all of us who are practitioners within this space acknowledge that there are 6 building blocks. So health system is a building that each of these 6 actually holds the building. So none of them is more important than the other. So we're talking about health financing, human resource for health, commodities, health information systems, service delivery, and health system leadership and governance. So these pillars play quite a big role in terms of this. But why health financing? So I view health financing as an enabler of all the 6. Because for us to have commodities, then we have to have clear mechanisms how we'll finance. For us to have health information systems, there is money. But again, you have to look at health information systems also enabling the flow of funds. So they are sort of quite related. So all these, they are related, but the financing bit becomes very, such an important enabler. So what becomes important, and especially as we do any other conversation, is it's not enough to fix one and expect the others. You have to be very intentional around how we fix the rest. So if we are going to say, yes, we have social health insurance, PhD fund, and all that, then the other question is, how does it relate to the commodity availability? How does it relate to human resources being available? And especially given the devolved nature of health sector in Kenya, I think that again brings in the complexity around the relationships, either, in terms of how the counties, are driving all these sort of conversations with unions to enable the fact that it's not enough for me to have a card, social insurance card, but whenever I go to the facility, I actually have the health worker there and the health commodities there. Yeah.
So I think what I hear from you is that there's no one important pillar by itself. All these are complementary in nature and they have to work hand in hand.
Yes.
For us to have a stronger health system.
Yes.
And just to bring you back to the point of what you do at CHAI, do you have an example you can share with us of what we've done with different governments within Africa that support this space?
Good. So I think one of the things that I mentioned earlier is different governments having different questions to answer, especially in the health financing space. Why is that the case? Because the governance structure of the different countries is different. So if you're talking about, for example, comparing Kenya and Uganda, neighboring countries, that their health systems are different based on the governance structures. Kenya is a more decentralized system, Uganda more centralized. If you look at it that way, but even for themselves, if you look technically, in their own way, it's decentralized because how the money is flowing is to the districts. But if you look at the governance structure, if you get what I'm saying. So one of the key things that we in the Clinton Health Access Initiative have been quite keen to do is be very contextual in our conversations with the different countries. So there is no one size fits all for the old countries. So for example, in Malawi, our bigger piece of work, Malawi heavily donor funded. A significant chunk of their budget comes from the donor funds. So if you look at a significant chunk of our work there, it's around how do we coordinate aid coordination, being part of it. How do we map resources to ensure that they're going to the right places to avoid duplication, right? So in that effect, it might not traditionally look like it's an innovative way, but it's actually something to enable a process to happen. If you're looking at, let's say, countries like in Rwanda, which I think you had mentioned earlier, so a well-organized, well-oiled machine in terms of health financing mechanism through this community-based health insurance. But over time, then the work becomes very specific around how do we become efficient with the resources to sustain the community-based health insurance. And that would be around the choice of how do we prioritize the services to be. And so we are very intentional in our work to support the prioritization of services. And secondly, yes, once you've prioritized, then we have to choose how do you pay providers?
Yeah.
Because how you pay providers influences how they behave and how they provide service and how you sustain. So provider payment mechanism reforms have largely been part of our work that we're supporting within that country. And so each of the countries, they're very specific kind of support based on what the government wants, without necessarily going in to define that this is what works because of all these differences.
I know you mentioned that you work with different governments and you look at every government's approach differently. But from your experience with the work you've done across the different governments, are there any specific countries that you would advocate for as a center of excellence where other governments can go and learn how they're doing in terms of health financing?
So, one of the elements that I mentioned is all these countries are different based on their governance structures, their approaches, and all this. So having to declare one as a center of excellence might actually not be very intuitive because, for example, if you're looking at a more decentralized system to learn from a more centralized system, there are very few aspects that they could actually learn. So let me walk through 3 countries that are more decentralized. So if you're looking at Kenya's structure around the counties, or Ethiopian regions, and Nigeria on states. So it's very helpful if the two have a bit in common in terms of the governance structure. So in terms of how they evolve systems, the funds flow to the evolved systems and finally to the facilities, becomes important for them to learn from each other, especially around the funds flow, because their governance structure is sort of similar. Looking at, again, if you borrow Rwanda and Ethiopia, so they are, having supported the 2 countries, I look at Ethiopia probably walking the journey that Rwanda has walked through in terms of setting up a community-based health insurance. So starting from the districts in Rwanda, so now we're looking at Ethiopia building it from the woredas, or the districts as they call them. And so it will be great for the 2 countries to learn from each other based on how this has evolved. Basically, that can help them leapfrog in terms of what they're looking at. If you're looking at another centralized system, for example, Malawi, Uganda, and Zambia, which are sort of centralized but have a district form in terms of how do we get money to the districts, finally to the facilities. And so what I'll be looking at, especially what we who are working to support the different countries acknowledge the differences in governance structures and where these countries are coming from, the context, and enabling them to learn from each other without necessarily pointing to one and saying, hey, go learn from Gabon, go learn from Benin. But it will be interesting for each of them to look contextually on the different pieces that they're having to learn from each other. Yeah.
Okay, fair enough. And just picking up from that conversation of different governments having different models and that's work for them. When you think about the partnerships that you have with the different governments, how do you then see the success here? How do you measure that success?
Good. So I think success in the health system, number 1 on the list is improved health outcomes. So let's keep people alive. Okay. So we're in the business of keeping people alive. And so all investments must result in saving lives. That's the primary goal that any health system should be. And so as we finance care, our success should also, it's not around the amount of money raised, it's not about the amount of money we saved, it's around the life saved. So that should be the fundamental kind of thought process that we do have in across countries and any other person that we're working with in the space.
Okay.
The other bit that becomes important around success is what we call financial risk protection. What does that mean? That let's let people not get into poverty by accessing care. Okay. So let's, as much as possible, cover them from that kind of, that kind of a catastrophe of them falling or having to forego their basic needs because of seeking care. So you can imagine households having to forego food for care or having to forego education for care. So we want to avoid such kind of circumstances. And that's why we have to reform our health financing platform to ensure that that happens. And finally, equity. So certain people are quite vulnerable and they are very disadvantaged. So one of the key things that we should strive to do is how do we mainly ensure access to care by those that are disadvantaged. And so if you look at a lot of approaches, it's been, if you're looking at, women, so there's been a lot of drive health financing and access to care for women and children, because in most cultures, and especially across the continent, we find them as vulnerable populations that we should be getting at. And of course, other groups, be it, the minorities in different countries that we're talking about, or even, the disabled, how well then are we taking care of them, the orphans and all that. And so at every step, what we aim to do is continuously see how we shape systems to respond to certain vulnerable populations so that they can access care. So our success is basically looking at how do we improve lives, how do we make sure that we protect them from, catastrophic health expenditures, and finally, how do we make sure that the most disadvantaged actually have access to care.
Not fair enough. And again, thanks for that, Dr. Matiko. So when you think about what we are talking about at the end of the day is how do we do this sustainably? Because at the end of the day, if you have an initiative and then it just stops, then it doesn't achieve the objective that it was intended to achieve. So in terms of ensuring that governments or the work that you do with government is sustainable, how do you ensure that?
So, back to the conversation we had around dependence on, let's say, development assistance for health or donor funding. So the primary goal that we're working on, that I think every partner should focus on, is how do we mobilize domestic resources. So by domestic resources within the borders to be and avail them for health. That should be the fundamental thing that we should be looking at. And also shaping health systems in that direction, shaping what we're prioritizing to respond to the needs of the population. Because in most cases, what tend to happen is, yes, we have money, but how are we prioritizing where the money goes so that it responds to the needs of a given population, be it in terms of the disease patterns or even in terms of the population dynamics. So if in most countries, especially in the continent, we know there are more younger people, how are we responding to, let's say, interventions on children? How we targeting interventions around adolescents, or even the elderly, the vulnerable population, how we're targeting those sort of interventions. And so it becomes important for us to imagine that, yes, let's mobilize resources, but those resources, let's also target them to the people that actually need the service. And finally, let's be more efficient in how we utilize those resources. I think once we approach it that way, then we're thinking about sustainability of those funds. The other piece that becomes quite important then is quite a focus around the outcomes that I mentioned. Because once we are clear around what we are going for, then we can even focus and think through how some of these pieces can happen. So being clear around what we want in the end as the end goal, which we emphasize that we are in the business of saving lives, that becomes very important for us to think about how can we sustainably mobilize resources, use it efficiently to save lives.
And coming just back home, I know transition between NHIF and SHIF, and there's been a lot of uproar. I know it's not a topic we're discussing SHIF, but just kind of put it into context. What would you say for someone who doesn't understand the transition by the government from NHIF to SHIF? Why do you think it's important for us to transition? And is it sustainable? Because one of the things that I've heard from most people is it's not giving the value that they would expect. What did you tell such a person?
So, probably, I'm sure at some point you'll have teams from the Ministry of Health to address this even further. But I think from a technical standpoint, the shift from... so NHF is now almost 60 years old, purely founded on the principles of addressing the employed, the formal sector, more so civil servants. So we look at, and a lot of people right now forget that NHF, at its inception, actually H stands for hospital. So what that meant, it was more of a hospital fund, National Hospital Insurance Fund. So what that meant then, what it was left, anything else outside the hospital was not within NHF. So over time, of course, there's been a lot of reforms, maybe for lack of a better word, I can say patchwork, to make it fit for purpose, especially to respond to the broader health needs beyond the hospital, right? But that has come with a lot of challenges in terms of then all it needs is to add one more pool, to add one more scheme, to add one more scheme. To date, I think NHF has about 80 schemes, quite fragmented, bigger chunk of them loss-making. But looking at how do we consolidate such kind of a scheme to a more simplified version. The thinking then was, can we, and I think lots of arguments, I don't know who's right, in terms of was it was it not easier to just reform an existing entity and actually make that happen? Or we had to form a whole different thing? I think that's a whole political conversation that in terms of how that will be. But now that we're here, I think it becomes important for us to acknowledge there are weaknesses within the NHF. There are strengths, of course, but there are weaknesses, especially around the setup. But then there are also strengths and weaknesses of the new setup that we're thinking about. But I think to give them the benefit of doubt is the thinking is right. How do we make it work? And especially around let's mobilize resources. Let's pool resources. Instead of having to fragment to 80 schemes, let's have a more consolidated fund that then can purchase care on behalf of Kenyans from the providers. I think right now the bigger challenge then is how do we actually get the money? Yes, we have figured out the formal sector. Yes. The informal sector remains a challenge. And then the next question is how do we get the money there to the service delivery points? Yes, FIF remains a good starting point. Is that the only one? It's more complex than that. So these are out of the dynamics, especially in an evolved system, that we have to think about. And so, yes, to the critics that are more skeptical, I guess quite a number are. What becomes important then is how is the government shaping or responding to some of the criticism, especially around, I'm giving 2.75%. What do I get in return? The other twist to that is, a social health insurance by definition is solidarity. Yeah. So basically, is you're giving in money, not just for you, but for the society. So that's another aspect that becomes important for us to think about as well. So, but again, that does not absolve the government from thinking about the value that I get from that social sort of solidarity that we're going to give in. Yeah.
So fair enough. So I think what I hear from you is it's a good idea, well thought out. Yeah. So we just need to make it work, and maybe we'll get the value that you are looking for if it works the way it's intended to work. Absolutely, and it will take time. I think one of the things that I have to be very honest about is, so I think right now the plan is October 2024, it starts. Will it be success right from the start? I don't think so. Will it require us to be patient? Yes. And what can partners, let's say KPMG, CHAI, and others support is around how do we make it work based on the fact that we still have the business of saving lives, and this is one of the channels. Thank you, Dr. Matiko. So looking into the future of this space of health financing, what do you see are the new trends coming up? What should we expect? Are there a more innovative way that are coming up that we should be thinking about already? Yeah, good. So I think if you look at it, the future, I'll probably look at the future in terms of from two lenses. One lens is, the supply side initiatives that are happening. So what sort of capital is coming in to improve infrastructure or the scope and scale of services being offered, not only in Kenya, but across the continent? And I think a lot of private sector investments, especially we are looking at PE firms or impact investors bringing in money into either private facilities or public facilities or even faith-based to improve the quality and scope of services. And I think there's been a drive, especially in the private sector, not only to just address the Kenyan market, but to look at, tourism, medical tourism as one of the approaches. And so on the supply side, what I'll be looking at is a future where we shape the market to be ready for investments. So for investments, be it by debt or especially in terms of the private sector, to prepare that. But on the government side is how intentional we are in infrastructure investments, human resource, creating a pipeline of human resources that enables to do that. But also clear mechanisms of funding commodities, through either pool procurement. There's been a lot of discussions around local manufacturing as one of the ways of lowering the cost of care. Those are things that we could explore on the supply side. On the demand side largely, relies on the fact that there's been a lot of work done on the supply side. So if I'm going to give you money to walk into a health facility, then it means I need to get the health facilities ready to receive me. And so for that to happen, and then which are the things that we must be very, very clear about is how do we mobilize those resources to enable them? So private insurance market in Kenya has largely remained stagnant. Why? Because, if you look at the premiums keep on going up, and I think it's become unaffordable to quite a number of people. And also just if you look at
the last 10 years, it has probably remained the same proportion that is covered. And so how do we shape the private insurance market to respond? And one of the key elements is the cost of care. All of them, when you ask them, the cost of care is driving the premiums up, and so cutting quite a significant chunk of the population out. So how do we shape the relationship between providers and insurers to ensure that the demand side on the private insurance is well worked out? For the public sector, especially when you're talking about social health insurance, which you've extensively talked about, especially the current legislation, is how do we, not only focus on the public sector, but even shape it to purchase care both on private sector and public sector. Just empower me, then to vote with my feet. So I'll go to where the quality is, where I get the most, but now adjudicate the quality, but at the same time adjudicate in terms of how the escalation of cost of care. So the future, I'm looking at it from those two lenses, but being clear that across the continent, that is likely to play out differently depending on how we shape the two. If we are more, in some countries that are more public sector centered, it's probably more to see what sort of role can the private sector play. And I think those of us who are working with the health financing space, it's about to shape that up. Those like Kenya, which is like almost 50-50 in terms of private sector, public sector interplay, becomes important to see how the two relate and complement each other. For those that are largely private sector, if you're walking down south, maybe to South Africa, then we see how do we shape that, not only to go to the drain of the escalating costs, but how do we save more lives with the resources available?
Yeah. Thank you. I think I see an exciting future coming up.
Yeah.
And I think all players should be ready to embrace innovative health financing. That's what I see.
Good. I mean, it's, I think maybe one of the key things whenever we talk about innovative financing, a lot of people try to look at innovation as, the word is there, but it's all about tweaking what was more traditional to a little bit more responsive systems to the changing ecosystem. So how do we continuously embrace changing ecosystem to sustainably finance care without necessarily having to think about how, I think the current world defines innovation.
Okay. Thank you. And Dr. Matiko, as we close the discussions for governments, organizations that intend to explore health financing more, what are some of the steps they should take? What would you advise them? Because really, this is a big thing. We need everyone to buy in. And some governments maybe are still slow in terms of embracing this change. Organizations that are also in this space that are also not sure what they should do. What are some of the steps they should take to be able to embrace this innovative health financing? Help us basically ensure that everyone is involved in this reform or in this space of ensuring that everyone, all people are covered in terms of healthcare. Yeah. And maybe as you answer that question, you also can just give us your closing remarks.
Good. So how can we ensure? So one of the key things is knowledge exchange. So how do we learn from each other? There's been a loud voice calling it south to south learning, that there's been a lot of focus to learn from the global north in terms of some of these approaches. But I think it's even more important we can learn from each other without necessarily having to look north in terms of what initiatives. Some of these initiatives that we call innovative are actually happening within the continent. Not only within the continent, but probably similar context in either South America or Asia that we can learn from. So, and I think one of the countries in the south that has been lauded most is Thailand in terms of the progress that it has made. So even as we look within the continent, it will be important to look beyond the borders and look at Asia, some of the approaches they're having to sustainably finance care with a budget not as big as what will be in the north to do that. So that would be an interesting bit in terms of partners like us. How do we enable that knowledge exchange? How do we not only, because sometimes, a lot of people confuse knowledge exchange in terms of, benchmarking trips. But it's around how intentional we are in harnessing the knowledge that is in different countries and transferring it to this and making it public. Because a lot of these issues happening, be it in a state in Nigeria, a region in Ethiopia, are probably just localized there. How intentional are we in bringing it up? I think for me, remains a key part that we regional partners should be able to do that. And I think for my parting shot, I'll probably say, health financing is not the end, is not the solution, the alpha and omega of of ensuring that we save lives is one of the knobs that we've got to move to make sure that happens. And so for us to make a move, we must at any point be cognizant of the other moving pieces. That yes, we are shaping health insurance, or we're shaping in terms of how much resources we're getting in to get to what you mentioned earlier in terms of, let's get to the 15% according to the Butcher Declaration. But we can even get to 20%. We are aware of many countries that spend significant chunk but not have a dent in terms of health outcomes or saving lives. And so it will be important for us to see, yes, we get here, but how do we efficiently utilize the resources? And how do we make the others work in terms of cost escalation on commodities, human resources availability? And also embracing, digitalization as one of the approaches of an enabling environment that we're able to track, and not only to, especially as we talk about NCDs, that we are not only able to screen, that we are actually linked to care, but even as we're linking to care, we're able to ensure that the physical and financial barriers are removed to access to care.
Thank you, Dr. Matiko, for sharing with us your insights on healthcare financing. Personally, I've learned a lot on the new trends that are coming up, and I'm excited to see what's coming up next. To my audience, thank you for watching us. I hope you also learned a few things on the innovations that are coming up in the healthcare sector. Looking forward to hosting you again in the next episodes. Cheers.
Thank you for tuning in to today's session. We appreciate your time and hope you found our conversation insightful. Be sure to follow us for more thought-provoking insights.